All right. Hi, everybody. Happy Monday. My name is Erin Abramson. I am currently serving as the deputy for the policy unit and the partnerships and risk management team for the COVID-19 response here at CDC. I would like to welcome you to today's partner update call on COVID-19. This call serves as a way for CDC to share weekly updates on COVID-19, along with our latest resources and guidance, especially for the private sector and other partners. Today's call will focus on CDC's strategy to address health inequities related to COVID-19. First, we will hear from our COVID-19 response Chief Medical Officer about where we are with the response and what everyone should know about protecting themselves and others. Then we will turn to our Chief Health Equity Officer to introduce CDC's newly launched Health Equity Strategy. Afterward, our speakers will take questions from the audience. Please note that this call is intended primarily for CDC partners directly involved in the COVID-19 response and is not intended for media. So, should media who are listening have questions, they are invited to reach out to media@cdc.gov. This call will be recorded and later posted on the CDC COVID-19 website, as well as on YouTube. All past partner calls can be found there, so please take some time to review and share prior recordings. If this is your first webinar with us, these weekly calls occur every Monday at 3 p.m. Eastern Standard Time. Please see the link in the chat box to subscribe to our mailing list to receive future CDC COVID-19 Partner Update webinar invitations. Note that there are multiple listservs that support this call. So if you have missed an invitation over the last few weeks, please click the link in the chat box provided to ensure you are on the listservs. I would also like to take this opportunity to remind all participants that the CDC website has the latest information, guidance, and communication resources. There are over 2,000 documents providing information and guidance for individuals, businesses, and the public on our website. In addition to the tools we will highlight today, some resources posted within the last 2 weeks include COVID-19 one-stop shop toolkits for a variety of situations, including childcare programs and summer camps, K-12 schools, youth sports, shared and congregate housing, parks and recreational facilities. And please know that these toolkits include videos, social media, PSAs, print resources, checklists, FAQs, and other guidance and web resources. We also have updated guidance on how to protect yourself and others, and public health guidance for community-related exposure. We want to thank those who sent questions in advance. We've already teed up a few of those questions, and I will also be keeping an eye on the Q&A box, so please feel welcome to submit questions there as well. Note that we will be using this and not really viewing the chat box, so please utilize the full functionality of the Q&A box. I am very pleased today to be joined by two CDC experts, Dr. John Brooks, our Chief Medical Officer for the COVID-19 response, and Dr. Libard, our Chief Health Equity Officer for the CDC COVID-19 response. For those of you logged into the webinar platform, there will be very few slides used today, so please don't be alarmed if they don't seem to be advancing. Now, I would like to turn it over to Dr. Brooks for some updates. Dr. Brooks.
Thank you, Dr. Abramson, and welcome everybody, and thanks for joining this call today. As mentioned, I'm John Brooks, and I'm the Chief Medical Officer for the CDC's COVID-19 response. And today, before we get into the main topic, I'd like to provide a brief update on the COVID response at CDC and some of the latest scientific developments and guidance. So a situational update looks about like this. Globally, we've reached 17.6 million cases and over 680,000 deaths as of August the 2nd. Here, domestically within the United States, there have been 4.6 million confirmed and probable cases reported to CDC, and tragically, over 155,000 deaths. Together, these represent 25% of both all cases as well as all deaths reported worldwide since the beginning of the epidemic, which is also more cases and deaths than contributed by any other country to date. Recent data are beginning to move in the right direction. They suggest that as a nation, we may be reaching at least a plateau in cases. However, progress varies substantially by state, some of which remain in the acceleration phase of the epidemic, where cases and deaths are steadily rising, whereas others are plateauing and others are showing declines. As you've heard me perhaps say before, and as others have said, deaths typically lag behind changes in diagnosed cases, and we're still seeing deaths increase since early June, since early July, which was their lowest point since the original surge in cases this past spring. The duration and severity of this current phase of the pandemic will continue to vary by state, and achieving control will continue to depend on a strong public health response, including increased access to testing and masking in public, widespread adoption of non-pharmaceutical interventions such as social distancing and hand hygiene. So that means staying at least 6 feet apart from others, covering coughs and sneezes, and avoiding touching your face, as well as routine disinfection of high-touch surfaces, increasing ventilation of the indoor environment, and of course, monitoring yourself and others for illness. And I'd encourage you, along with my colleagues, to visit CDC's COVID View, which is a weekly summary, or which maintains rather a weekly summary and interpretation of key indicators that have been adapted to track the pandemic in the United States. So I'd like to spend a moment talking about a couple of MMWRs that came out in the last couple of weeks that are relevant to today's topic about race and ethnicity and COVID-19. Scientists around the country and the world are working diligently to better understand how COVID-19 illness affects patients and communities. And today I'll share with you some of what we've learned. So first, on July 31st, CDC posted an MMWR titled Symptom Duration and Risk Factors for Delayed Return to Usual Health among outpatients with COVID-19 in a multi-state healthcare system network. So this was looking at how long it took people who had recently recovered from COVID to kind of get back to the place they were before they were diagnosed. And the findings of this study are noteworthy because they came from symptomatic adults diagnosed with COVID-19, but who were not hospitalized. So they had what we'd consider mild to moderate illness and not severe or critical illness. Relatively little is known about the clinical course of COVID-19 and return to baseline health for persons with COVID-19 who are managed this way as outpatients. We get a lot of data about inpatients, but not a whole lot about outpatients. So in this study, the median age was 42 and a half, and it ranged from 31 to 54 years, so young adults, basically. About half, 52%, were female, and 66% were members of racial or ethnic minority communities. In other words, were non-white and or of Latino or Hispanic ethnicity. Now, what researchers did is they called back participants 2 to 3 weeks after their positive test, to check how they were feeling. And at the time of this call, 35% of participants had not returned to their usual state of health, 35%. The most persistent symptoms included fatigue, cough, shortness of breath, upper respiratory congestion, and loss or change in smell or taste. Among the youngest persons, so I'm saying that because those are the ones we generally think will have the fewest symptoms and do well, among the youngest persons, and these were 18 to 34-year-olds, 26%, or about 1 in 4, had not returned to their usual state of health. These findings have very important implications for understanding the full effects of COVID-19, even in persons with milder outpatient illness. COVID-19 can result in prolonged illness, even among young adults without underlying chronic medical conditions, potentially leading to prolonged absence from work, studies, or other activities. And there's a lot of misinformation, as I'm sure some of you are aware out there, especially among young people and those that are otherwise healthy, that getting sick with COVID-19 is not a serious problem, that their symptoms will be mild, they'll recover quickly. You know, we all have a role to play in fighting these incorrect beliefs, so please continue to help us correct misinformation. COVID-19 can be a very serious illness and have effects that can last for weeks. You can protect yourself with simple measures by practicing social distancing, washing your hands frequently, and wearing cloth face masks in public, among others. So let me move on to the other 2 MMWRs. And first is one published July 17th, and this was titled Characteristics of Persons Who Died with COVID-19, February 12th to May 18th, 2020. So previous reports have shown that COVID-19 mortality is higher in older individuals and persons with underlying conditions. This new MMWR expands upon our understanding and provided more detailed demographic and clinical information about persons who died of COVID-19, including an investigation of racial and ethnic mortality differences. Overall, of the people under the age of 65 who died of COVID, 35% were Hispanic, 30% were non-white, and 13% were non-Hispanic white. So let me put this into perspective, because these are different than the fractions of each of these groups in the underlying general population. This disparity is really clear when you look at these numbers. So 35% of deaths were among Hispanics. However, only about 20% of the US population under age 65 is Hispanic. And 30% of the deaths were among non-whites, but only 22% of the US population under 65% is non-Hispanic, non-white. Conversely, only 13% of illnesses were among whites, whereas they comprise 57% of the US population under 65. This really illustrates that we need to better understand the factors contributing to these mortality differences to target our communication that encourages persons in high-risk groups to practice preventive measures and promptly seek medical care if they become ill, and not delay seeking that care. The healthcare system is now safe. Healthcare providers are experienced, ready, and equipped to receive patients and protect them from getting COVID-19. Help us make sure that people who may have any fear of getting COVID-19 in a hospital don't delay care for a potentially life-threatening condition. Lastly, the third MMWR, which appeared July 10th, titled Race, Ethnicity, Underlying Medical Conditions, Homelessness, and Hospital Status of Adult Patients with COVID-19 at an Urban Safety Net Medical Center, and this was in Boston in 2020. So we already know that older adults and non-Hispanic, Black, and Hispanic persons are overrepresented, as I've just illustrated, on hospitalized COVID-19 patients in the US, and that prevalence of COVID-19 is also high among residents of homeless shelters. This report found that among 2,729 COVID patients, nearly half were Black, approximately a third were Hispanic, and 1 in 6, or 1/6 were, sorry, 1/6, not 1 in 6, 1/6 were experiencing homelessness. These were overall data from persons cared for in both the inpatient and the outpatient setting. But if you focus just on the hospitalized or the inpatient setting, the proportions are different. The proportion of Hispanic patients in that circumstance was higher than the proportion of Black or of white patients. And this finding was most notable among persons aged less than 60 years. And whereas approximately 1/6 of patients overall reported being homeless, among patients who were hospitalized, approximately 1 in 5 of hospitalized patients were homeless. So a higher fraction of persons hospitalized who were experiencing homelessness. So like the report I described before this one, these findings also indicate the need to tailor our prevention strategies for persons from racial or ethnic minority communities, as well as persons who may be experiencing or at risk of homelessness. So doing can help us maximally reduce new infections, improve patient outcomes for those persons who become infected, and mitigate strain on the healthcare system overall. So with that, thank you very much for taking some time to listen, and it's now my great pleasure to hand you over to my good friend and colleague, Dr. Libard, to share information about CDC's health equity strategy.
Thank you, Dr. Brooks, and good afternoon, everyone. It's my great honor to be able to speak to you today to introduce our health equity strategy, and thank you for taking the time out of, I know it's a busy day, to join us. To accelerate progress toward reducing COVID-19 disparities and achieve health equity, CDC established the position of Chief Health Equity Officer in the COVID-19 incident management structure. And I have the good fortune to serve in this role, leveraging my experience as Director of CDC's Office of Minority Health and Health Equity. Today, I'm going to take some time to talk about CDC's recently released health equity strategy. And to begin, we define health equity as when everyone has the opportunity to be as healthy as possible. COVID-19 has exposed in plain sight decades, if not centuries, of inequities that have systematically undermined the physical, social, material, and emotional health of racial and ethnic minority populations and other population groups that are bearing a disproportionate burden of COVID-19, including but not limited to people who experience homelessness, as just described by Dr. Brooks, people with substance use disorders, justice-involved populations, people with disabilities, and non-US born persons. We all know that some racial and ethnic minority groups are being disproportionately affected by COVID-19. And factors that contribute to this increased risk of getting sick and dying from COVID-19 include discrimination, healthcare access and utilization, occupation, educational income and wealth gaps, and housing. Discrimination, which includes racism, can lead to chronic and toxic stress and shapes social and economic factors that put some people from racial and ethnic minority groups at increased risk for COVID-19. Discrimination exists even in systems meant to protect well-being or health, and some examples of such systems include healthcare, housing, education, criminal justice, and finance. Occupation plays a significant role in this epidemic. People from some racial and ethnic minority groups are disproportionately represented in essential work settings such as healthcare facilities, farms, factories, grocery stores, and public transportation. Some people who work in these settings have more chances to be exposed to the virus that causes COVID-19 due to several factors, such as close contact with the public or other workers, and not being able to work from home and not having paid sick days. We do not have to accept what is unacceptable. So now, speaking directly to the COVID-19 health equity strategy, CDC seeks to accelerate progress towards reducing health disparities and achieving health equity by adhering to these guiding principles. Our guiding principles are to reduce health disparities, to use data-driven approaches, to foster meaningful engagement with community institutions and diverse leaders, and to lead culturally responsive outreach, as well as reduce stigma, including stigma associated with race and ethnicity. We have 4 strategic priorities to reduce the disproportionate burden of COVID-19 among populations at increased risk for infection, for severe illness and death, and to broadly address health disparities and inequities related to COVID-19 with a holistic, all-of-response approach. So our first strategy is to expand the evidence base. Our second strategy is to expand programs and practices to reach populations that have been put at increased risk. And our third strategy is expanding program and practice activities to support essential and frontline workers to prevent transmission of COVID-19. And our fourth strategy is to expand an inclusive workforce that is equipped to assess and address the needs of an increasingly diverse U.S. population. We identified opportunities where CDC can accelerate and bolster efforts to reduce disparities. And we have also identified a number of critical activities already in progress. For example, recently a CDC team was deployed at the request of the state of Virginia to support the Richmond City Health District and adjacent Chesterfield County in addressing the rising number of cases in the Hispanic Latino community and challenges in mitigation efforts. So to learn about drivers of transmission in this community, the team conducted a survey in a primarily Hispanic Latino community of Southwood, where they conducted 2 focus groups with Latin American indigenous groups, as well as listening sessions, and they conducted key informant interviews with staff from a number of organizations. And what they found is that barriers to accessing medical care included financial barriers and those related to transportation, language barriers, and knowledge of where services were located. And so based on these findings, CDC encouraged the local Department of Health to hire Hispanic members of the community as local contact tracers and community health workers to assist in decreasing stigma. We also worked with the CDC Foundation to provide support to affected families, and are developing a plan for targeted messaging for employers, for independent contract workers, and factories to support outreach efforts. The Richmond City Health District Director recently reported back to CDC that since the deployment, they have hired 10 additional Spanish-speaking community health workers from the affected Hispanic Latino community. CDC is also supporting several what we describe as hyperlocal activities in African American communities, as well as Hispanic Latino, American Indian and Alaska Native, and Asian American, Pacific Islander, and Native Hawaiian communities through the engagement of trusted community-based organizations and institutions. We are forging partnerships nationwide and developing tailored communications, as well as mobilizing community health navigators, and promotores trained to deliver COVID-19 prevention messages and community mitigation strategies. These investments also include engaging minority-serving organizations. So as partners, you may be wondering how your organization can help reduce health disparities and inequities related to COVID-19 and support CDC's public health mission. We all have a part in helping to prevent the spread of COVID-19 and promote fair access to health. We must work together to ensure that people have resources to maintain and manage their physical and mental health, including easy access to information, affordable testing, and medical care. We need programs and practices that fit the communities where people live, learn, work, play, and worship. There are a variety of ways partners can support these efforts. For example, all partners can review and put into practice CDC's guidance on preventive measures, such as using cloth masks, social distancing, and frequent hand washing. Also, community and faith-based organizations can share COVID-19 prevention information using ways that you know are effective to connect with community members. And you might work with others to connect community members with goods, such as healthy food and temporary housing, and services to meet their physical, spiritual, and mental health needs. Employers can maintain flexible leave policies, provide employees with training and implicit bias, and how to identify and interrupt discrimination. Healthcare delivery systems can increase engagement with trusted community and faith-based organizations that have relationships with local communities and increase availability and accessibility of COVID-19 testing for racial and ethnic minority populations and other populations that are disproportionately affected. These are just some examples of actions partners may consider. A longer list of actions can be found on CDC's COVID webpage for health equity under What We Can Do. So as individuals and communities respond to COVID-19, there are often unintended challenges for important aspects of emotional well-being, such as social connectedness and social support. Finding ways to maintain support and connection even when physically apart, can empower and encourage individuals and communities to protect themselves, care for those who become sick, keep kids healthy, and better cope with stress. So CDC continues to facilitate partnerships between public health agencies, tribes, scientific researchers, professional organizations, community organizations, and community members to share information and collaborate to prevent COVID-19 in racial and ethnic minority communities. We welcome new opportunities for collaboration and feedback, and I thank you for your attention this afternoon.
Thank you so much, Dr. Libard. Thank you to both of our experts for all of their remarks, and I especially appreciate understanding some actions that we can all take to help reduce disparities and inequities related to COVID-19. I think that's incredibly helpful. I would love to start with some of the questions that we received ahead of time. And let's see, if I can, I would like to start by asking Dr. Brooks to answer a few questions for us. So Dr. Brooks, one of the questions we get a lot is, does having antibodies mean that you are immune from COVID-19 and that you can't give it to others?
That's a great question, because I think we hear this a lot, and a lot of people are out there getting antibody tests, and it's good to understand exactly what they mean and what they can be used for. In general, people develop antibodies after an infection, and a positive antibody test is presumed to indicate that the person who was tested has been infected, in this case with the virus SARS-CoV-2 that causes the illness COVID-19, at least some point in the past. It doesn't mean they're currently infected, and that's the first thing. You need to have that PCR test, at least right now, or an antigen test, which is a new form of testing that's coming out, to know that you're being diagnosed. The antibody just tells you that you may have been infected sometime in the past. Unfortunately, we don't have enough information yet to say whether someone will definitely be immune and protected from the risk of reinfection if they have antibodies to the virus, or that were they to be reinfected, they couldn't transmit it to others. We also know that not everybody seems to develop detectable antibodies after infection. So until scientists can get more data on how we develop immunity against reinfection and whether antibodies help protect us, everybody needs to continue taking steps to protect themselves and others. And as we've stated a number of times now, that includes social distancing by staying at least 6 feet apart from other persons when you're outside your home, even if you've had a positive antibody test. And we make a special point of noting to folks that this also applies to those who wear personal protective equipment as part of their job or at work. They also need to continue to wear the PPE, even if they've tested positive and have antibodies to the virus. Antibody tests should not be used to determine when somebody should return to work, and antibody tests should not be used to group people together in settings such as in schools, dormitories, or correctional facilities by putting all the antibody positive people over here and the antibody negative people over there.
Sorry, I had a hard time finding my mute to unmute myself. Thank you very much for that information. I have another question for you, if I may. If someone tested positive and had many of the symptoms of COVID-19, why would their antibody test come back negative?
Right, so scientists really don't know yet, as I mentioned, how to interpret the antibody test results, and this means both whether it's positive or if it's negative. And I just explained, we know that a positive test means that you've probably had the infection. We would count that as evidence you've had the infection, but we don't know exactly when that occurred. But we don't know, and we don't know if that means you're protected against reinfection. But now to answer the question that was asked, if it's negative, if you get a test for antibodies and it's negative, it could mean a couple of things. Of course, it could mean you never had the infection, or it could be too soon after an infection, if you had it, for the antibodies to develop. We often talk about a window period in disease, so that you may have had the infection, but it takes some period of time before the body responds to the infection and develops antibodies that can be measured by tests. So you could have been infected, but be in the window period. The good news is that these antibody tests are generally very accurate, and the good ones are over 95% accurate, but it's nearly impossible to be perfect. And these tests can, on rare occasions, give a falsely negative result. That means that you actually are infected, but it's the reaction is imperfect and it mistakenly is coming up negative. And then lastly is the point I was trying to make in the earlier question, is that there's some people who, despite infection, never develop antibodies. And we don't know why some people don't develop antibodies even when they were diagnosed with the infection by a PCR or an antigen test. Or if the absence of antibodies following natural infection means that you're immune to reinfection. So we have a lot to learn here, and right now we're using the antibody tests mostly to do epidemiologic work to understand where the infection has been and what communities it's moving through, but we're only learning now how we can use it for other purposes.
Very helpful. Thank you so much. One more for you. And then I'd like to go to Dr. Libard for a couple of questions. But this is one I think that a lot of us have a question about in our day-to-day existence. What should I do if I'm in a room with someone who doesn't want to wear a mask? Does CDC have any advice for approaching this kind of situation and communicating effectively?
Yeah, I think all of us have probably, in one way or another, come across that when you go out, you run into people. And I mean, you're like, what am I going to do? So look, the first thing that you can do that's under your, what you can do that's under your control is move away from the person, if that's possible. So step back, step away, maybe even leave the place you're in if that's something that's possible to do and you're feeling particularly uncomfortable. But in situations when others around are not wearing masks and you can't do that, it's especially important then to try and maintain at least 6 feet between you and the other person. And if this is in an indoor environment, also trying to make sure, to the extent that's under your control, that that there's good air circulation. You can open a window, turn on a fan, stand by the door, but the more outside air that we can move into indoor environments, the more it dilutes those respiratory particles that may be infectious coming out of our mouths and then reduce the risk of being exposed and becoming infected. I mean, simply moving away from the person, that's under your control, but as I pointed out, not everything else is. But we do all have a role in mitigating the risk of exposure to COVID. The risk of infection does not fall on one individual person. Preventing COVID really depends on all of us. So even if someone doesn't have symptoms, it's important. Even if somebody doesn't have symptoms, it's possible they're infected and with COVID-19 and they could spread it. And in fact, Debbie Birx this week said maybe it's time for us all to consider whether we start to behave as if we might be infectious. So if they're not wearing a mask, it's possible they could be unknowingly spreading COVID to others around them.
Yep. I've been operating from the start, just acting as if I am a carrier, like assuming that I have it and don't have any symptoms and treating everything that way. So wearing a mask all the time, et cetera, and keeping myself here and bored. So it's been a long few months. So I would like to turn to Dr. Libard, if I could, and talk a little bit more about the impact of COVID-19 on racial and ethnic minority communities. Dr. Libard, can we talk a little bit, why has it taken so long to understand the impact of COVID-19 on communities of color?
Well, as all of us on the line today know that this is a new virus, and we had very little information available about it at the very beginning. So early on, we had to rely on data from other countries to give us insight into who this virus might affect and then how it might affect them. But as more US data became available, it became apparent that COVID-19 was indeed having a disproportionate impact on communities of color. And as I've indicated earlier, we are working very hard to address this. I think it's also important to note that COVID-19 laid bare in plain sight social inequities that we've been aware of that have had a bearing on health outcomes for decades, if not centuries, in communities of color. But we can no longer be in ignorance about these disparities and ignore the social factors that are contributing to them.
So a little bit, to stick with that for a minute with Dr. Libard, why are members of racial and ethnic minority communities being impacted by this at such an alarming rate?
So as I've alluded to several times, it's really important to understand that this disparity is occurring because of systemic inequities that affect health and that have been in place over many years. There's a long history behind what we are seeing in the data today. And people who are part of a group that has been marginalized for many years because of race or ethnicity, because of socioeconomic status, sexual orientation, gender, disability status, geographic location, or any combination of these things are more likely to have shorter and less healthy lives. And in addition, over time, the unjust distribution of resources and opportunities also prevent access to nutritious food, to safe housing and good neighborhoods with good schools, and lives that are free from racism and discrimination.
Thank you for talking about that a little bit more. I would like to ask Dr. Brooks a question to expand a little bit more on why are underlying conditions that put people at risk for poor outcomes from COVID-19 more prevalent in communities of color?
Yeah, this is a complex question, and
yeah, I know that's a lot. I'm sorry.
No, but it's great. You know, it's a really relevant question because I think this cuts across all health in the United States. You know, I think as Dr. Libard has pointed out, this pandemic has really brought to light things that have been there all along and making us pay attention to them. And there's a long history of this in America. I just want to point out that you will have people who will always point out that there are certainly genetic differences between all of us that make some of us more prone to some diseases than others. True. But genetic differences by no means explain the differences that we are talking about here, which are much larger and much more pervasive. Groups that have been socially marginalized can have unequal access to the healthcare system. And so when you don't have equal access to the healthcare system, you can be prevented from getting preventive care and the medical treatments you need to lead a longer and healthier life. And then over many years, unjust distribution of resources and opportunities also prevent people from accessing nutritious food, as Dr. Libard pointed out, or good housing and good neighborhoods with good schools, and lives that are free from both directed racism and discrimination, but also institutionalized racism and discrimination. So these and other factors have led to higher levels of chronic conditions among Hispanic and Latinos and African American people in the United States relative to non-Hispanic whites. And these conditions are linked then to more severe outcomes from COVID, including death. And I just want to point out, I spend a lot of my time also working in HIV, and we've observed that when you take people from all walks of life and you even the playing field and they all can get access to the same level of care, these racial and ethnic differences begin to balance out a little bit. Even they may, in fact, they can be not entirely erased, but brought really way down. And that's because you need to have access to the same level of care. And that's why CDC is working hard to address the threat of COVID-19 in communities of color. For instance, starting this week, the government now requires, and I think Dr. Libard was getting at this, but I'm happy to say the government's going to finally require that reports of new infections contain information about the race and ethnicity of the person from whom the specimen was collected, as well as some general information about their geographic location, so that can help CDC better understand who and where people are being disproportionately affected, and then direct resources where those resources are lacking and most needed.
That's going to be really helpful. Thank you so much. There's a question in, I believe, in the Q&A box, and we've talked about this a little bit. For Dr. Libard, somebody was asking about gaps, things that were missing in the data. And I know we've talked a lot about why does CDC have gaps in race ethnicity data regarding COVID-19? Can you tell us a little bit about that?
Yes, and yeah, thank you for this question because it's come up a lot over the past months. And so just to explain what's going on right now, the large majority of COVID-19 case reports are initiated through automatic electronic reports that are sent to state and local health departments by clinical laboratories upon confirmation of COVID-19. So when someone tests positive. Now, typically, the laboratories themselves only have the minimum amount of information on the patient required to perform the test and report the result back to the healthcare provider that ordered the test. And this usually includes four things: the patient name, sex, their age, and the identity of the ordering provider. And so the fact that sex and age are commonly included on laboratory requisition forms because they are sometimes needed for interpretation of test results, this explains why these specific data elements are mostly complete in the COVID-19 case reports submitted to CDC. But even with the large investment of resources into responding to the pandemic that have been made available to state, local, tribal, and territorial departments of public health, what we find is that health department capacity to actually follow up and collect detailed data when it hasn't been completed at the level of the laboratory, their capacity to follow up and collect this detailed data on every case from providers and patients is far outstripped by the sheer volume of the COVID-19 case reports. And so as a result, the issues described above, kind of the detailed line list national COVID-19 surveillance database, is grossly incomplete for many of the requested data elements, including such important information as race, ethnicity, illness onset at diagnosis, the date of the diagnosis, any comorbidities that the person is presenting with, as well as their occupation, whether they're a healthcare worker or whether they are a grocery store cashier or some other essential worker. And oftentimes we also are missing the zip code of residence. So we're continuing, though, I'm pleased to say, to make progress in getting more complete data as we are continuing to work with the states and with our colleagues in the field.
And if I could just add, can I just add something? I just want to say this. I also think this is a really important point because I'm hoping that this extends beyond just COVID-19 testing. But if we can show you're able to do it and routinize it for this, then I'm hoping it can become standard of practice for all kinds of tests that we order.
Yeah, absolutely. And the more you think about it and the sheer volume of reports and cases and the amount of case investigation it would take to get the data that we need, yeah, we have to have a better way of doing this. Yeah, so I think that brings me to another question that I'd like to ask Dr. Libard, specific to our health equity strategy. So what are the next steps for the health equity strategy, and how does our data strategy kind of fit into that?
Yes, thank you. So first of all, I just want to remind our partners on the phone to please go to the CDC website and actually take a look at the strategy. It outlines not only the priority strategies that I described earlier, but also corresponding activities that we think will help us to achieve that strategy. And we also indicate some outcomes that we're seeking to be able to document in the next 3 to 12 months. And I also want to just reiterate that the work of health equity is one that will cut across our entire response structure. And we are regularly interacting very closely with the different task forces that make up the response structure, and therefore being able to tap into the expertise that's available across the task forces and being able to integrate a focus on health equity within those. So in terms of data, we're going to continue to improve representation and the interpretation of reported race ethnicity data through consultations, through reviews and analytic activities, which will lead to better information on how CDC should address racial and ethnic disparities related to COVID-19. We want to be all of our strategies and interventions to be data-driven, and we want to have the best data so that we can increase the precision of those intervention activities. We are also going forward in terms of immediate next steps, continuing to develop culturally and linguistically tailored health communications messaging, as well as collaborating with those critical partners like community-based organizations, the private sector, and non-governmental organizations that are able to reach communities at increased risk for COVID-19. We're in the process of reaching out across CDC to identify subject matter experts who can provide needed trainings. We're also developing supplemental guidance for our state and local health departments, for our project officers within the response, and also for field assignees to ensure that we have a well-prepared, well-trained, and diverse workforce, and that the interventions are indeed meeting the unique needs of communities at highest risk. We are continuing to build a diverse responder workforce within CDC, and we think about that diversity in terms of certainly racial and ethnic diversity, but also people who come from a range of social backgrounds and people with multiple disciplines. So we're adding our social and behavioral scientists to the pool. We're very much seeking people who are multilingual, and we're also very proud that we have a workforce that is multi-generational and brought together. We know that they can help to meet the unique needs of the community. And lastly, I'll just say we are finalizing a complement of key performance indicators that we will use to be able to monitor and assess progress across the response, and also to identify continued gaps in areas that are in need of improvement. So that's us going forward.
Yes, and for those that didn't see it yet, we did add a link to the strategy in the chat box. So that should take you directly to it. I do want to, let's see, I have a couple more questions here, and I know we are at 3:49. So a couple of important things. Dr. Libard, I want to ask you to focus just for a minute on what can be done, and then Dr. Brooks, I have a question for you after that. So specifically looking at public health emergency responses like COVID-19, what should public health professionals be doing to address some of these factors that disproportionately impact people of color, including our African-American communities and Hispanic Latino communities?
Yeah. So there are some things that we can do immediately, and our colleagues in the field, our public health colleagues, can do right away, which is to, first of all, to work with community leaders to host virtual town hall meetings. We've hosted several of those, and what they do is that they create opportunities for us to hear directly from people living in high-risk areas about the barriers they are encountering, and also be able to create a space where we can discuss potential solutions. I think the other thing that our public health colleagues can do is to reach out to trusted community-based organizations and institutions and ask them to help adapt COVID messages for their communities and share them broadly. And then to take what you learn from these community partnerships and create action plans that can be implemented in culturally and linguistically responsive ways. I would also encourage them to identify ways to support and work with essential and frontline workers, for example, people who work in healthcare and in the food industry and correctional facility workers. And then I would also say that what we can do right now is to consider additional training that will increase the effectiveness and our effectiveness as public health professionals in working with diverse communities and cultures. Take some time to learn about health disparities and the long history of inequities that have caused them. And then be thoughtful and proactive in exploring ways to do our work better. So I think that COVID-19, may very well represent a tipping point in our quest to achieve health equity. And I think we have the tools that we need to be able to move forward in a positive and kind of systematic way, and recognizing that we will continue to learn as we go along.
Sorry, that was me trying to look back and forth between two different things here, between our Q&A box and this other. So I see a question here about, how do we plan as CDC to connect with community groups and faith-based organizations, civic leaders, and other entities that are trusted by Black and Brown communities in COVID hotspots, and cut through the disinformation and the noise to reach those who are most at risk. And I feel like you did just address some of that.
And I can say
yeah.
one more thing about that, because because we're at the federal level, we are not, typically in communities, and when we're there for shorter periods of time. So what we've been doing is working through national organizations and national minority serving organizations who do have relationships at the local level. And we're collaborating and coordinating with them because they have the most direct access to the community, and they're the trusted partner.
Absolutely. And I want to see, let's see. I don't want to get too in depth on anything else unless our speakers have any additional closing remarks, because I always do this and then we end up cutting it right down to the wire and going over 4 o'clock. And I don't want to do that to you two. So I would like to give an opportunity for both Dr. Brooks and Dr. Libard. Any closing remarks on today's webinar around our health equity strategy?
Well, I'll go first, and I just want to first of all again thank all of our partners on the phone for being on the call today. And I also just want to say that CDC cannot do this alone. We cannot eliminate COVID disparities by ourselves. Public health as an enterprise, we can't do it alone. It's going to require the full engagement of communities, of the private sector, of employers, of policymakers, of social, civic, and other community-based organizations and faith-based organizations. And so I think that this is an opportunity or a historical moment where we have the chance to come together really in a unified way that is as unprecedented as this pandemic. And I think on the other side of it, we're going to see better health outcomes. So thank you again for your attention.
Thank you, Dr. Libard. And Dr. Brooks, any closing remarks for us?
No, it was remarkable listening to you, Dr. Libard. You're like saying exactly what I wish I could say as eloquently as you said it there. I mean, this really is our opportunity to start to get things right. And we depend in public health on the public to help us do that. And we look forward to you all joining us in this journey, because we are going to come out on the other side. It will probably be a little bit rough, but we are going to come out on the other side.
I like that. This is our opportunity to do it right. Thank you both so much. This concludes our time together. Thank you everyone for joining our call today. A recording will be posted online on CDC's COVID-19 webpage. The subscription link, again, to receive future updates and invitations is listed in the chat box. So please take a look for that if you haven't already. Thank you again, and please join us next week. I believe, will be providing some links and resources and tools that are focused on our Spanish-speaking communities. So thank you so much, and we look forward to talking with you next week.